Hello, my name is Matt Strelo, and this is the third part in our series on shock. So back to our case of a 70-year-old female that we've identified as having severe sepsis and early shock. We decided she had distributive shock, which is a combination of fluid leak and vasodilation in most cases, where the arteries have dilated out due to either endotoxins or other things released by the tissues themselves, and the capillaries in general have become leaky, where fluid is leaking out into the extravascular space. How are we going to treat our patient then with septic shock? And the cornerstones of treatment are antibiotics, IV fluids, vasopressors, and monitoring the patient closely. Antibiotics are important to give early in patients with severe sepsis and septic shock because over the last decade or so, what's been shown in retrospective studies and large databases is that early antibiotics can improve survival. So giving antibiotics 1 hour versus 5 hours after recognition of severe sepsis or septic shock dramatically alters the survival curve. And the same is true as time progresses. And if you give the antibiotics after 24 hours, patients have a dismal chance of surviving. The other thing that's changed over the last few years is that the way we give the antibiotics. Traditionally, we would give antibiotics in a very narrow spectrum to cover what we think is the most likely bacterial source of the infection. And then over time, we would broaden this coverage as blood cultures or other cultures came back, or if the patient didn't improve in a timely fashion, we'd broaden the coverage to try to cover more organisms that may be causing the patient's infection. But what we've noticed over the last 5 to 10 years has been that we want to flip this around. And what we want to do is start with broad coverage initially to make sure that we don't miss that initial dose of antibiotics covering the source of infection. In fact, one study showed a 5-fold increase in the patient's mortality rate if the first dose of antibiotics did not cover the bacterial source in that patient. A 5 times elevation in mortality, so pretty dramatic. So what we now do is we give broad spectrum antibiotics early, and then we want to taper those antibiotics down to avoid resistance in our bacteria in the first 1 to 3 days during the admission of the hospital. And so we start broad and we taper quickly. Moving on to IV fluids. How do we give IV fluids? Well, in the vast majority of patients that come in to the emergency department setting or are seen in clinic or are just being seen in the healthcare setting, they can tolerate a large bolus of fluids when they have sepsis to start with. And most guidelines recommend now a 30 ml per kilo bolus given in anywhere from 30 minutes to 1 hour. And crystalloid is an appropriate choice. It's not been shown that colloids are of any benefit in most patients over crystalloids early on. So we're going to use either normal saline or lactated ringers. We then want to monitor these patients closely for signs of shock, and we want to monitor these patients for signs of fluid overload. And the signs that I typically look for are increasing respiratory rate, decreasing oxygen saturation, and then on lung exam, are they starting to develop crepitations or crackles? If you do see signs of fluid overload in these patients, then you want to hold your IV fluids at that point and not continue to aggressively push fluids. Now, after our initial bolus of IV fluids, we then want to determine whether the patient is going to respond to continued fluid resuscitation. And that concept is now called the concept of fluid responsiveness. Fluid responsiveness really means that after you give the patient a bolus of fluid, is their cardiac output going to improve? because what we're trying to do by giving fluid is improve or increase the cardiac output, thereby increasing the perfusion to tissues and vital organ systems. So, we want to check, is our patient fluid responsive? The simplest or one way to do that would be to just give the patient a 500 cc bolus over 10 minutes and see, does the cardiac output increase appropriately? Most of the time people say an increase of greater than 10 or greater than 15% in the cardiac output after a 500 ml bolus is appropriate. Anything less than that would be a limited or a small response. So how are we going to check fluid responsiveness in the average patient? Well, we measure cardiac output, we then give a fluid challenge, and then we measure our cardiac output again. Unfortunately, it's not quite that simple because we don't have a great method of estimating changes in cardiac output in the vast majority of patients where we don't have a lot of monitoring in place or invasive monitoring available. Things that people have tried have included looking at the blood pressure, the CVP, the IVC, the left ventricular end diastolic area, using ultrasound, using pulse pressure differential. All of these have been tried as a marker of cardiac output in patients. None of them have been great or highly successful at this point, and so we're really using a combination of all of them to estimate cardiac output. The one that we have the most ready access to in the vast majority of settings is just checking the blood pressure. So let's talk about that for a minute. So we're going to monitor our cardiac output, and then we're going to give a fluid challenge. And we have a couple of different ways we can give a fluid challenge. The easiest way is just to give the patient a 500 ml bolus of fluid and do it over 10 minutes or less. And that's a good fluid challenge. Unfortunately, in a patient who you think may be getting volume overloaded, or a patient who's getting frequent reassessments, you don't want to be doing a fluid challenge every 30 minutes, every hour with a 500 cc bolus when you think they may be getting volume overloaded. So you need an alternative method. Another way to do it is to do a passive leg raise test. Well, what is a passive leg raise test? A passive leg raise test is really taking the fluid that has accumulated in the lower extremities and rapidly transitioning that fluid in the vascular space, in the veins, and moving it into the thoracic cavity and moving it back to the heart. In essence, giving them a fluid bolus. So we start with a patient in a 45-degree semi-recumbent or semi-upright position. We then drop the head of the bed, raise the legs to 45 degrees. And what this does in essence is give the patient about a 200 to 300 ml intravascular fluid bolus. And the effect lasts for about 30 to 90 seconds. So it's transient. So we won't volume overload a patient because that fluid will then rapidly distribute into the splanchnic circulation. Now let's see this in practice. So we have a patient, we check the patient's blood pressure, she's in the 45-degree semi-upright position. She's been in that position for at least 2 to 3 minutes before we start the test to let fluid accumulate in the legs. We drop the head of the bed to flat or supine, and we raise the legs to 45 degrees. We hold this for about a minute. After a minute, we then recheck the patient's cardiac output. In this case, we're using systolic blood pressure as our marker of cardiac output. So that's a passive leg raise test. If you're going to use systolic blood pressure as your marker of cardiac output in response to a passive leg raise test, it would be considered positive if the systolic blood pressure increased by more than 17%. That patient would be considered a fluid responder. And we know if we continue to give that patient IV fluids, there's a good chance their cardiac output will increase significantly, more than 15%, and that the patient's perfusion will improve, which is the goal of giving them fluids. So in our patient, our 70-year-old woman who had septic shock, we gave her antibiotics. We gave her initial fluid bolus of 30 mLs per kilo of normal saline. We repeated her vital signs. Her heart rate was 120. Her blood pressure was 85/45, respiratory rate of 30, and saturation now of 98%. So we assessed this patient then for signs of fluid overload and responsiveness. Her signs show that she has an increased work of breathing, but we don't hear any crackles or crepitations at this point. So we decided to do a passive leg raise test to see if the patient would be fluid responsive. And when we perform the passive leg raise test, her systolic blood pressure only increases by 5%, so really not much change at all, suggesting that the patient may not be fluid responsive. However, it's really important to realize that the systolic blood pressure is not a great marker of cardiac output. And so if the systolic blood pressure increase is less than 17% after a passive leg raise, that doesn't mean the patient won't be fluid responsive. That just means that the test was inconclusive and you don't really know which way. If it's more than 17%, we definitely think they will be fluid responsive, but less than that, it's an inconclusive test. But given that our patient also has some signs of fluid overload and increased work of breathing, I think at this point we can say that we've tried fluids and that we should probably move on to vasopressors in this patient. And the first line vasopressor in patients with septic shock is noradrenaline or norepinephrine. If for whatever reason we need to use a second line, it's generally considered adrenaline or epinephrine. And we want to titrate these vasopressors to a systolic blood pressure of greater than 90 or a MAP of greater than 65 millimeters of mercury. So how do we know, what do we do if the patient doesn't respond to our first vasopressor? So we should start with norepinephrine or noradrenaline, okay? And if we've used this and we've titrated it up and the patient still has hypotension or hasn't met our goals, at that point we're going to assess their cardiac output and put them into one of two categories: the patients that have a low cardiac output or the patients that have a high cardiac output. The patients with a low cardiac output are going to be the patients that are cold and clamped down. They have a high systemic vascular resistance, but for whatever reason, their cardiac output is not adequate, so we don't think that their heart is able to pump against that high systemic vascular resistance. In those cases, in order to increase perfusion to our tissues, we're going to add an inotrope, some inotropy, and then we can do that by adding dobutamine to our regimen of noradrenaline, or we can stop the noradrenaline and switch the patient to adrenaline, which has both vasoconstrictive properties like noradrenaline and inotropic properties like dobutamine. The second category of patients would be those patients that have a high cardiac output, which you may see in patients with distributive or septic shock. And in these patients, the cardiac output is actually elevated, but the systemic vascular resistance is very low, so the blood vessels are very dilated and you're not getting good perfusion of the tissues. In these cases, we want further peripheral vasoconstriction, so we're going to add low-dose vasopressin to our regimen of noradrenaline. What about monitoring these patients? Well, we want to make sure that we're doing frequent assessments of the simple things like the vital signs, checking them for fluid overload like we talked about. We want to evaluate our core things again, like the shock index, the mental status, the urine output, and the skin perfusion. And then we want to consider other monitoring, oxygen saturation, cardiac monitoring, because these patients are at a high risk, especially if they're on vasopressors, for dysrhythmias. We want to consider checking a CVP, and if we don't know if the patient is fluid responsive or not based on our early testing, a CVP can help us and actually make it more accurate to use the systolic blood pressure as a marker of cardiac output. And you should consider serial lactates, especially if that initial lactate is elevated, and primarily if it's elevated over 4, trying to see a 10% reduction or more in that lactate in a 1 to 2 hour period. In summary, we want to administer broad-spectrum antibiotics early when managing patients in shock. We do want to tailor these antibiotics to some degree to where we suspect the infection from, but if we're not sure, we want to make sure we don't miss with the first antibiotic coverage. We want to give aggressive initial fluid resuscitation, especially to patients that are new to the healthcare system and probably are dehydrated or intravascularly volume low. And then we want to monitor patients closely for signs of fluid overload and fluid responsiveness. And finally, noradrenaline is our first-line vasopressor for most forms of shock, including septic shock. Thank you.